Right, here we go. So I was tell you a story of London over the last 5 years and what we've done. And I think it's an important story for a whole host of reasons. And I'll happily meet and talk to people through the day about this and take questions. So, here's me in 1963 sitting on my dad's knee. And my dad looks a bit shocked, doesn't he? You know, he's, blimey, all this lot, where did they come from? Yeah? My mum looks a bit cheeky, doesn't she? Yeah, she's looking at him sideways, because you never really know what's in the data, do you? Because the apocryphal story in our family is, Mum has just told Dad, oh, and there's another one on the way. There you go. Number 8 was due. And the other important link for this story is that, you know, we're all baby boomers in this family now. We are creating the health demand. You know, health services are keeping us alive. We all have comorbidities probably. We all take some drugs of some sort. But as we get older, we will need more support. And that growth in demand of baby boomers is not going to drop off till about 2040. That's a big part of the demand. And we're not going to solve that demand question by doing more of the same. We have to do things differently. So how can we use data to drive the difference? So I like to think of it in these terms. I like the concept of the learning health system and the thoughts of Victor Zhao about the knowledge generation and making clinical data research grade. And I like to think of Charles Readman saying that data is available consented immediately and routinely. It becomes part of normal cultural practice. And I also set this in the context of this children's story, Kobe Yamanda. And it's about how an idea promulgates, really, and I would encourage you to go and read it. It's not about what the idea is, but it's how relationships work that's the key to it. And we know that it's people first in what we do. So I guess my proposition is it's all about the data. You know, what can we do at the point of care with data? What can we do to support improvements at scale? And what puts patients in control? And I don't think putting patients in control is just letting them see their record. I think we've got to come up with tactics that allow patients to enter data about themselves and have proper dialogue with the care system and be equal partners going forward. And that is the future where we need to get to, and we just need to be open and explicit about that. I don't think we are open and explicit enough about it yet. Behind all of this, though, I think is leadership, because we need some brave leadership to make some decisions to help take this forward. And I see that in some places, I don't see it everywhere. But people need to stand up and be counted and be prepared to have different views and have those different views heard. Because it's all about patients. And this is one of the stories in London. Bramwen, she had a cancer. She was seen in several different institutions. In each of those institutions, tests were repeated, scans were repeated. There was probably a delay of 18 months in some of her diagnostic measures. So, you know, we've got to stop that, right? We've just got to stop that. And we can if we work together. And this is London. As was introduced, it's a fairly complicated place. There's about a 10 million population, lots of different organisations. Interestingly, and I wasn't aware of this till I looked at it, there are sort of around 40 universities in London. We often think, don't we, of the UCLs and the Imperials and the Queen Marys and the Kings, but actually there are lots and lots of universities and IHEs in London. And we've got around 24 different EHRs. Now, 24 different EHRs, but over an installed base that's much bigger. So each one that's installed is different, okay? It may have the same name on the outside, but it's different. So you've got to do different things because we have been very poor at reducing the variation in our installed base. So we've got two big products in London. We've got Cerner's, or now Oracle's HIE across the whole of London, and we've got Better's openEHR platform. We've got a load of standards, right? I mean, you know, so it's not just about one set of standards or two sets of standards, it's how does this whole ecosystem work together? And so we've got to find a way of the partnership moving forward. If we can collaborate, I think we can do that. But what I often observe is that there's sort of slight fights between different standards bodies, and we've sort of got to stop that. You know, that is really important, and it's great to see the work of people in this room and the foundation that's behind this driving this forward. So we start with the work we're doing around platforms in London. And if you look on the bottom, I don't know if this laser works, yes. We've got about 5 or 6 different platform things we're doing across London. So we've got a London Care Record, we've got the Universal Care Plan, we're doing work in mental health, we've got 8 mental health trusts. And patients at the interface of all these organisations get a very raw deal. We've got the 999 Transfer of Care programme, where we're electronically transferring data now from ambulances into hospitals, into A&Es, to pre-reg those patients in A&Es with their clinical data that the ambulances find. That's working in one trust, will roll out over the next 18 months. And we've got a data strategy programme, because what we've recognised is, whilst we build all these broad approaches, it's got to end up with the data, because the data ends up being the starting point for the next way we move forward. So the London Care Record is quite a big thing now. There are several HAs across London. We've connected quite a bit of outside of London up into the north as well, and we're working in other surrounds around London. It covers most of, not quite everything, I would say. Probably 95% of everything is connected. And it's a very straightforward exchange mechanism, view at the point of care, in context. You'll all be very familiar with it, but it works well. It works well such that our doubling rate is about 11 months now. And when I look at September's data, there's over 2 million views of that across about 100,000 different health professionals in September. We have commissioned an external review through Queen's University Belfast, and that's demonstrated that it's probably saving between £2 and £3 million of time now every month. This is available online at the onelondon.online website to view. And so in terms of the investment in this very straightforward technology, it's repaying an awful lot, but it's done more than that. It's built trust amongst our service community in London that we can operate at scale and you can all benefit from it. And it's the trust that's the important bit, right? Because it's these stories for these moments of care that make the difference. You know, I was able to give better support in the ambulance, freed up an ambulance. The care has improved, having access to path results. Just very simple things all the time. But that's only a starting point, and it's a passive mechanism. So we've got to take the step and move to other things. So then the second platform is the Better Universal Care Plan. About 4 years ago, we had a product in London called Coordinate My Care, which had come out of the Royal Marsden, which was an end-of-life product. It was very bespoke. It was built on an old InterSystems platform, I think. And it had some traction, but not much. And contracts for that were becoming end-of-life. What we knew was we wanted to have a way of bringing the London Care Record and this work together going forward. And so after quite a lot of work, we decided on an openEHR platform. We decided on Better as the main partner, although there are a number of partners in that work, I have to say. And that now is doing great things. The biggest change is that from January this year, patients can view their own care plan in the NHS app in England. And then the second thing we've done is extend this not just from end of life, but to patients with sickle cell disease. And the learning is, it's not a digital program. We've got to get the clinical specialists and the patients to own these programs. So who are the group of specialists who will own end of life? It's the palliative care physicians across London, a strong network. Who are the clinical professionals that own the sickle program? And that's specialist haematologists across London. So as we extend this, and we will extend this into frailty and a group of other conditions, December time, it's getting those clinical specialists to own it, to have initial conversations with the patient. But then there's a step beyond that now, which is into the new year, we will start to allow patients to make changes and start recording their own data natively through the app without permission of anyone else. And that is a sort of sideways move into this concept of being patients being an equal partner in this work going forward. And we'll see how it goes, right? It will, I'm sure, need a lot of effort and support. When we look at the care plan and look at the end-of-life work, and see some stats, we see that the use of that has doubled in the last year. You see the chart here, it's doubled. We would expect about, in 10 million, about 100,000 people to sadly die every year in London. This is recording about 75,000 new people every year. And of those that died in September, because I can give you data very quickly, and I knew this in the third week in October, I think about 69 or 70% of those died in their place of choice. When I look at data from elsewhere in England, it's about 55%. So we've still got a failure rate, right? But it's massively improved. And that's probably, patients feel better about it, but it's probably making more efficient use of services as well. The other thing on this chart I'd like to point out is this number here, 40%. So the link is embedded in many places to the Universal Care Plan, but it's also embedded in the shared record across London. And most of the referrals into the Universal Care Plan, that 40%, are through the shared record. So you need, I would say, another way of getting that out there so that every user who's doing something can get to it easily. And if that were an insurance website, we'd be getting a lot of income from that transfer, wouldn't we? It would be creating us income, but it's not. So then, I come to this trust issue with our publics. And I think we still have a legitimacy gap. Where we are moving from is this fragmented world. Where we need to move to is this integrated world. And many people are suspicious of services bringing data together and using it for multiple purposes. So in London, just before the pandemic, so in 2019 and into early 2020, we ran a very large public deliberation, sampling about 3,000 people across London with questionnaires who had been case matched across London from all sources, and then bringing 100 of them together over 4 days with health professionals to educate them on our problems, for us to understand their problems, and for them, our publics, to come up with a set of recommendations. And these are the public's wordings of how we use their data. And we said, 76% and 21% agree, so 97% strongly agree that they expect all health and care organisations to use data for direct care. And then the next one, 70 and 28, so 98 expect health and care organisations to join up depersonalised information as part of population work and as part of research. So there is very strong support. There are some exceptions, but there is very strong support for this, and it's one of our key features around trust. The first one is building trust amongst our own communities. The second is building trust with our publics. And we have followed that up with more or less every 18 months another deliberation about various elements of this, ending up on the right here with sort of 100 people who we now use as a clinical advisory group into our work across London on a pretty routine basis. But what of the data then? And I like to talk about these two stories. So on your left is a coxcomb chart that Florence Nightingale drew around the Boer War. It's well known, it's a radial chart. Distance is the measure from the centre, and you can look at deaths from various causes. I prefer this chart though, and I prefer the story behind this one, which is John Snow. It's actually cholera that was the problem, but John Snow was called into Soho and people were becoming ill and dying. The black bars here are the charts he drew of where people were sick or dying. And he knew from his apprenticeship in the northeast, because he'd been down the mines, that there was a link between this sort of disease that he'd seen before and water. So he mapped the distance to water pumps, and there's a water pump here, and the nearest one he either locked or saw off the handle, and people stopped dying, people stopped getting ill. And I like it because that is a story which has got both the insight and the action, that learning health circle. It's really important we think about not just getting to data, but why we're getting to data and how we're going to use it to drive that improvement. So another example of why data is important for a different purpose And this is the data which encapsulates 3 of the integrated care systems in London. It was produced in early January 21, so just about the time as we start to vaccinate with the AstraZeneca vaccine, for those who remember the detail. And it's GP visits or GP contacts over 3 ICSs, so about 6 million people in this chart. Monthly, you can see things like, you see winter peaks, you see Christmas dropping down, you see another winter peak, and then you can see the pandemic, March, April. The colours, green is face-to-face, red at the bottom is telephone, and you can see a large increase in telephone at that point. And then you can see a large increase back in face-to-face. And the total, which is in blue, at this point, going into Christmas and January 2021, you can see there's about a 15% increase in activity in primary care. And this was the chart that was used with the Secretary of State, Matt Hancock, at the time, to get, I think, about £150 million into primary care for that purpose, because he did not believe that there was extra activity going up. And we used that chart and produced it within a day. So what purpose are you going to use the data for? And there are multiple purposes. So in London, we have pump-primed our work around data by putting money into a number of projects around asthma and air pollution, around cancer, around cardiac disease and prevention, and around preschool immunisation. And we've did this with the principle that scale is really important. So it's no good you just doing this locally or within your integrated care system. You've at least got to get this working in 2 integrated care systems, and ideally 3 if you want any follow-on money. And in all 3 of those, they all got some success in 2. 2 of them, the immunisation one and the asthma one, have got work going in 3 ICSs. Because adoption is our biggest problem. We're very good at getting to data now, I think. It's getting much better. We're very good at getting insights. That's getting much better. What we're not good at delivering the change in services that we need. And so we have another set of projects that we're pump priming going forward. And then I want to just take you through one other broad project that I was able to lead with HDR UK, which again came in 21. It originated because, if you remember those people with the AstraZeneca vaccine, a small number of them were becoming ill with blood clots in their brain and being admitted, and some of those were dying. And there was a surveillance system, a manual system amongst haematologists set up to report on these twice a day. We asked our question, can we do it with data? And the background was there were no UK national data feeds coordinating this sort of data. It's a little bit better now, but still not where we need to get it to. And that first question there was, show me all the COVID vaccination patients 5 to 30 days after vaccination in the ED, presenting with a thrombosis with these potential features. And so actually trying to get that data out of systems and link it and then run some standard analytics on it to identify these patients was quite hard. We had about 10 million population across England in various places. We did get some insights from it. There was only one place that were able to do it on a daily basis, and that was in East London with the clinical effectiveness group there and with Barts Health. And we were able to advise haematologists the day after, go and look at this patient that's been admitted because we think they may have this condition. They've got the same characteristics, and some we found, some were not right. And then we extended that to work in ambulatory care for A&E attendances to look at variation. So, some results for the first one. The alignment was not very good, and we couldn't get an instance out because the data were too small. But we did reduce the time by a mean of about 32 days to report, and that was significant. And then we see the huge variation in the way A&E patients are discharged with low significance conditions, a 300% differentiation in discharge, and the same for people with potential heart attacks when their blood test says that they probably don't have a heart attack. Again, a very wide variation. So in these, we're trying to find reasons why we can go and improve our services. What's the next question we ask ourselves? And we have a set of recommendations, but they're really everything that we've seen before. Why are we not using standard data in standard ways at standard scale to do all of this? So really what we're moving to is this proactive care world. But we also need data for our planning and our sort of standard business intelligence, and we also need data for our research. So historically, we have tended to build different data sets for all of this. But I think a proposition now is that we build one data service with sources from all of this and our shared work across London, using what I would say are the 6 safes for a whole set of purposes. And we would call the whole of this environment our secure environment. And I think that is a big change, and it's really good that across London now, all our academic, NHS and City, City Hall and councils have agreed that they'll take this single approach to this going forward. Interestingly, in one of our patches, this data set is now on a FHIR query, providing the GP data into the shared record. We previously used the MIG for that, for those that know that. So we're finding ways that we can use this data for all sorts of purposes, which help us become more efficient and effective. But going forward, we've got this question, because all our contracts are up in the next 2 or 3 years. We need to keep improving our user experience. We need to focus on patients. We need workflow in there. We've got some workflow, but not enough. We see, particularly through our urgent care work, we're not alerting our systems, we're not bringing our patients into those conversations. So this general request around communication and how that works is really important. I've been told to stop, so we're not long. We need data insight. We've got to get the right standards in there, but the standards community needs to help us with this. And we need to do it in reasonably quick time. We can't spend 20 years or 10 years. We've got to do this in a 3 to 5 year timescale, I think. And so when we look, we've got a set of options we might choose on. We keep going as us with a mixed set of systems. We consolidate all of this, HIE 2, I'm not sure that's going to work. Although we move to a data-driven approach across the whole health economy, or some sort of hybrid. And we are starting to actively look at about what version 2 looks like. And it's interesting we're doing this at the same time as we see nationally, people talk about a national health record and what that means. I think there is a relationship between these two, and we would hope to be able to influence that. But I take you to this slide of Jodrell Bank, for those of you who know it, and Sputnik, which the Russians sent up in 1957. So I think we've all got to look for our Sputnik moments. And Jodrell Bank was a publicly funded research project arising from really the Second World War and radar, but wanted to look into space and understand what these sort of signals were. And it was running into trouble. New technology, not going very well, lots of public money, people asking for it to be stopped. The Russians sent up Sputnik. It was the only station outside Russia that could tell the world what the Russians were doing. Overnight, it fell away. So what's our Sputnik moment? And I would say our Sputnik moment is probably the pandemic, but we've sort of lost it a bit since. We haven't kept our common focus. The other story here is to get to this Sputnik moment for London, we've had to go by a slightly circuitous route, because now I'm not sure we'd say that the shared record was the first choice. And you can see there I am, a little bit older. I'm the mucky one in the front. So we have a vision. I won't go into that. National work, national things often fail is the message from this. So this is in England, 7 administrative regions. Something called a 4-hour standard for people who should be discharged from A&E. We track that over the last few years. Every region's the same. You can see a slight difference in the pandemic effect in London here. So all these national initiatives, they don't give us what we need. So how do we empower local services? And we've got to get local services being able to use their data with their patients to empower. And I like the thinking and the work of Peter Senge. This is from 1985. It talks about obvious solutions often failing, because they make things worse, because we underestimate complexity. It talks about time. It says we often expect in complex systems things to happen quickly, and they don't. They take time to happen. And the third one is my favourite here, complex systems. And by complex systems, of course, it means people. Yeah, I'm being told to stop again. Very close now. To resist attempts to change. Because of compensating feedback relationships, people say no. And the last 2 give us some insight to that. So my last 3 slides these Canada geese give us some insight into the way managers should work. The leader moves. They don't take all the pressure. So we don't all need to lead. We can share that with each other. It's a really important metaphor. If we don't, we end up in this Hitchcockian moment. Although I used this in the pandemic and said Hancockian, for those of you in England who will understand the joy of that moment. I did take these two photographs myself. I didn't take this one, which I think is AI, but some of you will be able to reverse Google it, tell me where it's from. Sort of working together, the metaphor for how we work together to drive the future forward. Thank you very much.
Perfect timing. Just one very quick question. You mentioned that national ideas or national projects don't work, but there is an ambition to have a national single care record. How do these two things go together? And One London is just one of the single care record cities or projects in the UK. There's others. How do you collaborate? So how is that vision going to come together?
Yeah. I think my answer is going to resonate with the openEHR community. So to have a strategy, you need to have vision. To deliver a vision, you need a plan. And to deliver a plan, you need agreements and resources. So it's all about the implementation, right, at the end of the day. So how are you going to implement it and how are you going to make that work? And that is often the weakness in some of the national ideas that come forward. The delivery is weaker than it needs to be. And, the more we extract delivery to a national level, the more we'll fail to use our local people who have all the benefits to gain from this. And so we dissociate local effort from a national plan and make it work. So I think use local and get it going through local, but focus on your implementation.
Thank you, Luke. It's a conference topic by itself, the use of resources and implementation.